So the gold standard for bladder cancer detection is we're all very familiar. We see the rigid cystoscope and flexible cystoscope and white light. And let me be perfectly clear, you know, it still is the gold standard, but the real question is can we do better? So there's so many disruptive technologies, markers, imaging, therapeutics, which are going to be discussed, and the data will be reviewed at this meeting, which is really why this is a great meeting. And I'm going to talk a little bit in my presentation on how can we become better resectionists? How can we enhance our use of cystoscopy, whether it be rigid or flexible, and do a better job in identifying malignancies of the bladder and doing a better job resecting them? So why do we talk about this? Well, bladder cancer, from a health economic standpoint, how often have we all heard it is one of the most expensive malignancies because of the prevalence and because of the chronicity of care that's involved. And if you can read through the data points here as well as the graph, looking at how it compares to other solid tumors and the cost, and we'll talk maybe at some of our panels regarding value-based models of care, which is very important as we're moving away from volume to value-based care. And so are there technologies, are there imaging ways that we can do a better job at identifying significant malignancy of the bladder and being better resectionists? So the treatment, surveillance, and recurrence contribute to this very high economic burden. And there's really not much controversy about that and how we need to do a better job. And that's achieved by partisan support in the legislature. So I'm going to talk about blue light. I'm going to talk about a green light as well. There is no yellow light that I'm aware of, unless somebody else wants to talk about that. But we know about white light. So let's first talk about blue light and cysview. Here's the FDA indication. This comes right from the label. It's an optical imaging agent indicated for the use with cystoscopic detection of CIS amongst patients suspected of known to have lesions on the basis of a prior cystoscopy or in patients undergoing surveillance cystoscopy for carcinoma of the bladder. It's approved in the United States with Karl Storz equipment in conjunction with blue light and insertion of a porphyrin derivative. And it's an adjunct to white light. It's not as an exclusion to white light. So I think that's a very important point to be made. So the blue light cystoscopy, or with cysview, previously in earlier iterations when it was being developed by Photocure, it was called a Hexvix. But essentially what this is instilling a photosensitizing agent into the bladder via a catheter. And we were one of the primary beta sites, you know, over close to 10 years ago in my clinic, and started using it. The agent goes into the cellular membrane of the tumor. It interacts with the hematic biosynthetic pathway, and it has intracellular accumulation. And then ultimately, as you can see here, you see in rapidly proliferating cells, transitional cells of the urothelium, there is uptake. And after an hour of indwell, then when you go to do cystoscopy and the wavelength specific to blue light, you can visualize, it's quite remarkable going from white to blue light, and you can actually see areas of carcinoma in situ or margins of papillary tumor that heretofore you might have thought were not seen. So the proof is actually in the visualization. So here are actual examples. And these are white light utilizing right now. The blue light has been inserted with the cysview technology. And what you're seeing right now is just white light settings in all four of these panels. And then when I move over here, you can see what it looks like to see the tumor highlighted. And it really is very dramatic. And you can pick up on CIS and you can pick up on papillary lesions. Small lesions is particularly valuable in these high volume cases, or even potentially a very large tumor around the margins. So there's been a lot of pioneering work and here's another example, and this is from Sia Donishmond and Angie Smith. And this was actually taken from work that was done in trials that this led to the approval of cysview in flexible cystoscopy. But you see another really nice example, and if you look at the white on the left and the blue on the right, you can see how this makes you a better diagnostician, and then it arguably improves your resection capability. So let me just go through this fairly quickly. There is an extensive body of evidence. There have been a half a dozen, frankly more now, multi-center global phase 3 trials in Canada and US and Europe. Actually, it's north of 2,300 patients now looking at it. And essentially, at the end of the day, we see an improvement in papillary tumor detection. If there's an improvement in visualization, it doesn't take too much of a leap to recognize it makes you a better resectionist in comparison to white light. I'm going to show you a table in a minute that's sort of a meta-analysis of lots of different studies, but I'm just going to highlight a couple for purposes of time. At the end of the day, the blue light cystoscopy improves detection about 20.6% of patients with recurrent bladder cancers. These are the ones that just become the nemesis of taking care of these patients, whether it be low grade, intermediate to high grade, particularly worrisome in the high grade group, and particularly worrisome for patients who have missed carcinoma in situ and its propensity for progression. So kind of a busy slide. Just to really focus on, I'm going to really just show you a couple of slides on the stencil paper, which led to the approval back in 2010, the Danishmand recent paper published in Journal Urology. But there's really been, as you can see in the locations, really globally encountered. It's really the standard of care throughout most of Europe. And frankly, it's a significant standard of care, I believe, in north of 90% of academic centers in the United States. There hasn't been as much traction within the community, and part of that I'll get into has to do with the requirement for storage equipment solely, and also some of the economic reimbursement issues. And thanks to both LUGPA and SUO, as well as with help of the AUA, we are really working collectively along with Beacon and Photocure to improve reimbursement so that patients can get full access to the, so that clinicians who want to use it are not subjected to an economically losing proposition. So here's the Arnold stencil paper in July in J Urology in 2010, a North American European study, 28 centers, randomization was performed centrally, and they looked at basically, as you can see the schema here, initial randomization and then a second randomization within the patients for comparison. I'll just jump right ahead to the bottom line here. 16.4% of patients were found to have greater than one or more additional Ta-T1 tumors with the blue light versus white light alone. And patients with tumor were detected with blue light with Cysview, 46% of CIS. The false positive rate was actually fairly comparable, but you can still get false positives. It's not a perfect finding. And here's a recent paper from Sia Danishmand that was in 17 different sites looking at patients with non-muscle invasive bladder cancer at high risk of recurrence. Randomization, as you can see in the schema, looking at blue light, white light. And also what was nice about this is it led to the approval now in February of this year, or last year I should say, in 2018 for the approval of utilizing blue light in flexible cystoscopy cases, and also demonstrated that the infusion or the installation intravesically could easily and safely be given more than one time. So the findings here was that 20.6% of patients with recurrent tumors were detected only with the blue light. 34.6% of patients with CIS tumors were detected only with the blue light. So you can obviously, as a urologist, think clearly deduct the downstream implications of the enhanced detection. And what was also, you see in a survey here, and you could read through this, but about 27% of patients would have a change in the management by using the blue light. And that could have been less aggressive to more aggressive endoscopic resection, or more aggressive thoughts about intravesical therapy or repeat resections. So here's just another analysis. At the end of the day, what's nice to see, that technology's been around for quite some time, for more than a decade, but all phase 3 trials demonstrated that the blue light provided a statistically significant improvement in detection, and there has been data as well on improving or enhancing the recurrence rate of blue light versus white light alone. That said, we're still looking at, and we need to do more studies in regarding the question of progression and survival. So this is just, again, another example of the meta-analysis now in 9 studies, seeing the increased rate of detection for patients with blue light versus white light alone. Again, doesn't preclude the use of white light, utilizing both. The technology stores equipment only. You have to buy a processor or a tower. There's cost associated with that, so a little bit more of a challenge where you're economically constrained as opposed to tertiary and academic medical centers. But that said, it's not so much of a barrier in Europe where they are agnostic to the endoscopic equipment. A Beacon Bladder Cancer Advocacy Network basically demonstrated patients really found this of value. And to more and more the sophisticated patients out there in various parts of the world, inclusive of the US, are going onto websites. They're wanting to know, are you offering the latest and greatest of technology? And that's why I have that slide up here. As I mentioned earlier, in February of this past year, FDA approval for use in flexible cystoscopy, which converts it from an ambulatory surgery center, if you're only doing rigid, to an outpatient clinic facility. Here's another company. They're doing some pioneering early work at University of Rochester with Ed Messing, known as iBlue imaging system. They basically purport having a requirement only for a 15-minute indwell time as opposed to the hour dwell time, but it's still a work in development. Let's talk about green light, or narrow band imaging. Works by filtering white light into specific wavelengths, not intended to replace histopathologic sampling, and is agnostic to endoscopic equipment. And you could see a nice example of a white light versus the green light, just simply when you flip the wavelength. Here's a series of articles, probably the best one published years ago by Harry Herr at Sloan Kettering. But you really see the numbers are much smaller. You don't see the global multi-institutional studies that you've seen with the blue light that I showed you earlier. But nonetheless, it has value and can be beneficial for making you a better diagnostician, potentially enhancing your resection capability. Here's a table basically allowing you to see sort of the cross comparisons. What are the pros and cons? A little bit more extensive study in the blue light. In the green, you don't have to do an installation or a dwell time for an hour. There appears to be certainly more data on detecting CIS not visible with white light. There's really a paucity of cancer outcomes. There can be more cost associated with the equipment purchasing with the blue light. So the AUA and the SUO guidelines, you can read these here. These are now current, up-to-date, 2019. A clinician should offer blue light with Cysview at the time of TURBT, if available, to increase detection and decrease recurrence. Recommendation is grade B. Similarly, with the narrow band imaging or the green light, it's a grade C. And for the yellow light, it doesn't exist because there is no yellow light. Okay. So my final slide, which I got 12 seconds. At the end of the day, we want to do as full a resection as safely as possible, as complete as possible. We want the correct grading and staging. It's ultimately optimal for patient outcome and for cost savings. Thank you very much.